Welcome to the deep dive. If you are joining us today, you are likely a medical student, a junior doctor, a public health trainee, or maybe a practicing clinician looking to seriously sharpen your conceptual frameworks.
Right, because we are building a structured conceptual companion here. The goal is to help you actively master the architectures of public health.
Exactly. And for this discussion, we're focusing on information systems and population screening. We're drawing really heavily on the foundations laid out in the Oxford textbook of global public health, specifically chapters 4.1 and 11.4. So keep those chapters in mind as your analytical guide while we talk today.
And to anchor our entire discussion today, we should really start with a specific way of visualizing these systems. Think of modern public health in high-income countries as a giant, incredibly complex living organism.
I love this metaphor.
Right. It works so well because for any complex organism to survive, adapt, and protect itself from external threats, it fundamentally needs two biological mechanisms. First, it needs a central nervous system.
Which, in the context of public health, is the information systems, right?
Exactly. It's the vast, interconnected web of data.
Yeah.
It takes raw, disparate data from millions of clinical encounters and transforms it into actionable health intelligence.
And the second mechanism?
The second thing the organism needs is an early warning radar system. This is population screening. It's an active, systematic process of scanning the horizon, looking for incoming threats in a population that otherwise appears completely healthy.
The organism metaphor works really well because it takes something that usually feels like, dry administrative bureaucracy, databases, registries, spreadsheets, and it frames it as a living, breathing sensory network. And that brings us to the mission for this deep dive.
Which is definitely not rote memorization today.
No, not at all. We won't just be listing out the criteria for a screening program or naming different types of databases.
The focus is on building robust conceptual frameworks. We want to trace the logic from risk to exposure to outcome and finally to system-wide impact.
And a major part of this will be differentiation, right? Because the frameworks in public health often overlap in ways that can be, highly confusing in clinical practice.
Very confusing.
Yeah.
We have to draw hard lines between things like surveillance versus screening or lead time bias versus length time bias. The goal is to strengthen your clinical reasoning so you understand the underlying why behind major health system decisions, rather than just accepting the what.
Before we jump in, a quick pledge. While public health policy can obviously intersect with political spheres, this deep dive remains perfectly neutral. We're looking purely at the data, the ethics, and the systems described in the Oxford text.
Just the science and the systems.
So let's start with the first half of that metaphor, the nervous system. When you look out at a massive population, say a country of 60 million people, how does the public health organism actually know where the pain is?
How does it know what's making people sick?
Right. We have a variety of foundational building blocks for public health information systems, and I want to break these down beyond their basic definitions. Let's start with the absolute bedrock layer, vital statistics. This is essentially death certificates and birth counts. But surely it's more complex than just tallying up the numbers at the end of the year.
It is significantly more complex, primarily because of the categorization of that data. Vital statistics represent the ultimate, undeniable endpoint data of the system. But the analytical power isn't in the raw count. It's in the trends.
So looking at how causes of death shift over time.
Precisely. Death certificates routinely track the specific underlying causes of death using standardized international coding. This is how epidemiologists monitor population-level trends for specific threats. If we want to know if a specific strain of hospital-acquired infection, like MRSA or C. difficile, is becoming more lethal, we look at the vital statistics. We use it to track drug-related deaths or suicide rates over decades.
But there has to be a vulnerability there, doesn't there? Like if I'm a junior doctor covering a night shift and I'm asked to fill out a death certificate at 3:08 a.m. for a patient with multiple comorbidities, the accuracy of what I write down as the primary cause of death versus contributing factors might be, highly variable. Doesn't that human element skew the bedrock data?
It absolutely does.
Yeah.
That is a fundamental vulnerability of the system, and it's why nosologists, the professionals who classify diseases, play such a critical role in public health. A tired clinician might just write cardiopulmonary arrest as the primary cause of death.
Which is a mechanism, not a disease.
Exactly. The system requires continuous quality assurance and standardized training to ensure that the underlying cause, say ischemic heart disease or a specific malignancy, is accurately captured. But despite those friction points, when you aggregate it across millions of records, vital statistics allow researchers to identify crucial macro trends.
Things like excess winter mortality.
Right, or the undeniable links between mortality rates and socioeconomic deprivation.
That makes sense. The sheer volume smooths out some of the individual reporting errors. But vital statistics only tell us about the end of the road. What about the living population? How do we capture data on behaviors or symptoms that haven't resulted in a hospital admission or death? This brings us to the next category, which is population surveys.
Unlike vital statistics, which are a passive byproduct of vital events, population surveys are active intelligence gathering. They're designed to seek out information that simply isn't captured anywhere else in the clinical ecosystem.
Like what kind of surveys?
Well, consider the U.S. National Health Interviews Survey. It targets roughly 40,000 households annually. Or the Behavioral Risk Factor Surveillance System, which is a massive telephone survey reaching hundreds of thousands of people.
But why go through the massive expense of calling hundreds of thousands of people? Don't we already have their medical records?
Because a medical record only tells you what happens when the patient decides to interact with a doctor. It doesn't tell you about their daily diet, their exercise habits, or whether they're experiencing activity limitations due to ill health that they just haven't sought treatment for.
Right, the invisible health issues.
Exactly. If you want to understand the prevalence of smoking or the barriers to accessing care, you cannot pull that from a death certificate or a lab result. You have to actively ask the population.
So surveys fill in the behavioral gaps, but they rely on self-reporting, which has its own biases. I mean, people might underestimate how much alcohol they drink or overestimate how much they exercise. Let's contrast that active questioning with administrative databases. These are completely passive, right? They're like the digital exhaust fumes of the healthcare system.
That's a great way to put it. Administrative databases exist fundamentally to manage the logistics of the healthcare system. Their primary purpose is paying bills, tracking bed occupancy, and managing clinical waiting lists. However, from a public health perspective, they are an absolute goldmine.
Give me an example of one.
A prime example is the Hospital Episode Statistics, or HES, in England. This system captures details of all admissions, outpatient appointments, and accident and emergency attendances at National Health Service hospitals.
To give some scale to that, we're talking about tens of millions of records every single year. It's capturing the primary diagnosis, any secondary diagnoses, the operations performed, the demographic profile of the patient, how long they waited for care, and where they live. It is a massive data warehouse.
And the inclusion of geographical data is what makes it so powerful for health intelligence. Because HES tracks where a patient is treated versus their home postcode, researchers can map patient flows. This is crucial for evaluating the equity of service distribution.
So if an administrative database shows that patients in a highly deprived postcode are consistently waiting 3 times longer for a routine joint replacement than patients in an affluent postcode just 10 miles away,
Then the system has identified a structural inequity that requires intervention. It's right there in the data.
Okay, so administrative databases give us the broad strokes of healthcare logistics and diagnoses. But what if we need deep, highly specific clinical nuances? If I'm an epidemiologist studying a specific type of cancer, HES might tell me a patient was admitted for chemotherapy, but it won't give me the granular details of their tumor markers or specific outcomes. That's where registries come in. How should we differentiate a registry from just a standard administrative database?
A registry is a highly organized, targeted system. It uses observational methods to collect uniform, detailed clinical data to evaluate specified outcomes for a population defined by a particular disease, a specific condition, or a specific exposure. While an administrative database captures a little bit of information about everyone, a registry captures a massive amount of specific information about a select group.
Let's look at the different flavors of registries, because there isn't just one type.
Broadly, we see 3 main categories. First, there are product registries. An example is a national registry of patients who are prescribed advanced biological therapies for autoimmune diseases. The goal here is long-term pharmacovigilance tracking rare side effects or efficacy over decades.
And the second type.
Second, we have procedure registries. A classic example is tracking every patient who undergoes a carotid endarterectomy.
Why track a specific surgical procedure so closely?
To evaluate the quality and safety of surgical care. By registering every procedure, public health officials can monitor the complication rates and mortality rates of different surgical centers, or even individual surgeons. It provides an objective baseline for clinical governance.
That makes total sense. And the third type?
Finally, we have disease registries, the most famous being cancer registries. These systems enroll a patient at the very moment of pathological diagnosis and meticulously follow their entire clinical journey, capturing the tumor staging, the specific treatment modalities used, and long-term survival rates.
So we have the vital statistics, the active surveys, the passive administrative data, and the deep dive registries. But over the last few decades, the nervous system has undergone a massive evolutionary leap. We have to talk about the electronic health record, the EHR.
The transition from paper-based clinical notes to structured digital records is arguably the most significant infrastructural development in modern public health. When health systems collate anonymized EHRs, the analytical potential is staggering. Take the UK, for instance, where general practitioners act as the gatekeepers to the broader health system. Almost all primary care encounters are digitally recorded. Databases like the Clinical Practice Research Data Link, the CPRD, collate longitudinal, anonymized data from millions of patients.
And it's not an isolated phenomenon. I mean, the Dutch have the Pharmo record linkage system, collecting demographics, pharmacy dispensing records, and hospital morbidity data for millions of inhabitants. Scandinavian countries leverage their universal civil registration systems to link patient registries across their entire populations. In the U.S., initiatives like the Rochester Epidemiology Project capture comprehensive healthcare information for the population of an entire county.
This requires a fundamental perspective shift for anyone practicing clinical medicine. When you are in the clinic, it is very easy to view the EHR purely as an administrative burden, a tool for billing, or at best, a digital notepad for managing the specific patient sitting in front of you. But that framework is just too narrow.
How should a clinician be thinking about their data entry then?
When you select a specific diagnostic code, when you record a patient's smoking status, or when you document an adverse drug reaction, you're not just writing a note, you are actively building the sensory input for the public health nervous system.
So the quality of your input matters globally.
Absolutely. The accuracy, the completeness, and the specificity of your daily clinical coding directly dictate the quality of the health intelligence that agencies rely upon. If clinicians use vague codes, the system's vision becomes blurry. If coding is precise, the system can detect subtle epidemics, accurately evaluate the safety of new drugs, and allocate billions of dollars in resources effectively.
That is a phenomenal way to reframe the daily grind of clinical documentation. You are the sensory organ for the wider system. But let's push this further. Here's where it gets really interesting. We have all these massive, distinct pools of data, a primary care database here, a cancer registry there, an administrative hospital database over there. Data sitting in silos is limited. How do we wire these distinct systems together?
This is the concept of interoperability and data linkage, and it represents the synaptic connections of our nervous system metaphor. A general practitioner's record is highly valuable in isolation. It shows when a patient presented with a cough or when they were prescribed an antihypertensive. But the real transformative power is unlocked when you link that primary care record with a hospital admission database and then link both of those to the National Death Registry.
But the moment we talk about wiring all these systems together, we hit a massive wall, which is privacy. Healthcare data is the most sensitive information a person possesses. We can't just merge databases containing names, addresses, and mental health diagnoses and hand them over to researchers.
No, we absolutely can't. The governance of this data is just as important as the technology. The system must balance the societal need for comprehensive health intelligence with the fundamental, non-negotiable right to individual privacy. To achieve this, health systems utilize a mechanism known as the Trusted Third Party, or TTP.
Walk me through the actual mechanics of a trusted third party. How does it protect the patient while still allowing the data to be linked?
The TTP acts as a secure, legally bound intermediary. Let's say a research team wants to link primary care records to a national registry of acute myocardial infarctions. The primary care database and the hospital registry both send their patient identifiers, things like the national health number, date of birth, and postcode to the trusted third party. They do not send the clinical data yet.
Just the identifiers.
Correct. The TTP uses those identifiers to accurately match John Smith in the primary care system to the John Smith in the hospital registry. Once the match is securely established, the TTP utilizes cryptographic hashing. They strip away all the identifying information and replace it with a unique, randomized, anonymized research number.
So the final data set that actually gets handed over to the epidemiologist is a timeline. It shows that patient X visited their GP with a specific symptom on Tuesday, and patient X was admitted to the cardiac ward on Friday. But the researchers have absolutely zero capability of finding out who patient X is.
Precisely. It is a system of pseudo-anonymization. It preserves the longitudinal journey of the patient across different healthcare settings, which is vital for complex research, while heavily protecting individual privacy.
Let's look at what happens when this linkage is done successfully. I had a huge aha moment reading about the Caliber program. It's a perfect illustration of this. Caliber stands for Cardiovascular Disease Research using linked, bespoke studies and electronic health records. They took longitudinal primary care data and linked it with the National Registry of Acute Coronary Syndrome, hospital admission records, cause-specific mortality, and even layered in postcode-based social deprivation data.
The Caliber program demonstrated the absolute pinnacle of what linked, anonymized data can achieve. One of their specific studies looked at the relationship between respiratory infections and heart attacks. Researchers had a hypothesis that influenza could act as a trigger for an acute myocardial infarction.
But how do you prove that without locking thousands of people in a room and exposing them to the flu?
You used the linked data to conduct a self-controlled case series. They looked at the hospital registries to find the specific individuals who had suffered a heart attack. Then, using the linked primary care data, they looked backward at those exact patients' GP records. They were looking for consultations for flu-like illnesses in the weeks immediately preceding the heart attack.
And because it's a self-controlled series, they are comparing the patient's risk during the flu window to that same patient's baseline risk at other times of the year.
Yes, and the linked data definitively proved that acute respiratory infections, like influenza, significantly increase the short-term risk of an acute myocardial infarction. It is a brilliant example of uncovering a systemic truth.
Because no single doctor sees the whole timeline.
Exactly. The GP knows the patient had the flu, but might never know they went to the emergency room for a heart attack 3 weeks later. The emergency room doctor treats the heart attack, but has no visibility into the fact that the patient saw their GP for a severe cough last month. The individual clinicians only see fragments. Linkage connects the dots and reveals the full clinical picture.
It's the nervous system firing across different lobes. Now, Caliber is an example of retrospective research looking back at years of data to find a pattern. But public health also requires real-time reflexes. We need to talk about syndromic surveillance.
Syndromic surveillance shifts the focus from confirmed retrospective data to early predictive signals. It is the practice of monitoring clinical encounters for specific symptoms or syndromes that might represent an emerging infectious disease or a biological threat, rather than waiting days or weeks for confirmed laboratory diagnoses.
Because if a novel respiratory virus hits a city, by the time the labs confirm the pathogen, sequence it, and report it up the chain, the virus has already been spreading exponentially for 2 weeks.
Exactly. Time is the critical variable in outbreak response. For example, systems can monitor weekly consultation rates for flu-like illnesses across thousands of general practices. If the system detects a sudden, statistically significant spike in patients presenting with fever and cough in a specific geographic cluster, it triggers a public health alert long before the lab results confirm an influenza epidemic.
The Massachusetts Department of Public Health built a fascinating system for this. Instead of asking busy doctors to manually fill out forms when they suspect a notifiable disease, the system automatically extracts data from electronic health records every 24 hours. It pulls vital signs, diagnostic codes, and laboratory test orders, and runs them through automated algorithms to detect anomalies. It essentially removes the reliance on human memory and administrative compliance.
Automated extraction is highly effective. However, we have to introduce a strong caveat when we move away from structured clinical data and look at unstructured open-source data. A few years ago, there was massive enthusiasm for using internet search queries like Google Flu Trends as a form of syndromic surveillance.
The logic makes sense on the surface. If I wake up with a fever and body aches before I ever call a doctor, I'm probably going to type my symptoms into a search engine. If millions of people do that, you should be able to track the spread of the flu based on IP addresses and search terms.
The initial logic was compelling, and early models showed that search query volume correlated highly with outpatient visits for flu-like illnesses. But this raises a fundamental question about data validity and human behavior. While the search trends correlated with doctor visits, they eventually failed to correlate accurately with actual laboratory-confirmed influenza.
Why the divergence? If people are searching for flu symptoms and they are going to the doctor for flu symptoms, why isn't it the flu?
Because healthcare-seeking behavior, and especially internet search behavior, is heavily influenced by the media. If a new, highly publicized strain of the flu dominates the 24-hour news cycle, people become anxious. Healthy people with a mild sniffle or just the worried well will start searching for symptoms and booking GP appointments out of an abundance of caution.
Oh, I see. So the signal gets buried.
Completely. The surveillance signal becomes entirely swamped by the noise of public anxiety. The algorithms couldn't distinguish between searches driven by actual infection and searches driven by reading a news article. Therefore, syndromic surveillance must always be carefully calibrated and cross-validated against hard clinical endpoints.
You can't just trust the raw digital exhaust. You have to understand the psychology driving the data generation. Before we move on to how this data actually changes clinical practice, we should touch on two aspects that heavily influence the quality of this entire nervous system. First, there are key performance attributes that govern these systems. Second, there is the human element, the analysts. Let's start with the attributes. If I'm designing a public health information system, what metrics am I trying to optimize?
You are constantly balancing 5 core attributes: completeness, timeliness, accuracy, representativeness, and accessibility. And the challenge is that these attributes are often in direct conflict with one another.
Give me an example of that conflict.
The most common friction point is between timeliness and accuracy. Let's say there is an outbreak of a severe gastrointestinal illness. The public health agency needs data rapidly to identify the source. Is it a contaminated water supply or a specific food distributor? If you wait for perfectly accurate data, fully confirmed stool cultures, meticulously audited clinical coding, peer-reviewed case files, it might take 3 weeks. By then, the accuracy is 100%, but the data is useless because the outbreak has already peaked.
So you have to sacrifice accuracy for speed.
In emergency surveillance, yes. You might rely on syndromic surveillance of emergency room admissions for vomiting and diarrhea. The data might only be 75% accurate, capturing some people with unrelated food poisoning, but it is available in 12 hours. You accept a lower degree of accuracy to achieve the timeliness necessary for immediate intervention. Conversely, if you are building a cancer registry to study long-term survival rates, timeliness is less critical, but absolute accuracy and completeness are paramount.
And what about representativeness?
Representativeness asks if the data accurately reflects the underlying population. If you build a digital health app to track physical activity, and you generate millions of data points, it feels like a massive success. But if the only people downloading the app are wealthy, health-conscious individuals in urban centers, your data is not representative. It tells you nothing about the physical activity levels of elderly, rural, or marginalized populations. Building policy on unrepresentative data actively widens health inequalities.
Which highlights why the technology alone is entirely insufficient. A database doesn't interpret itself.
This is the crucial human element. You can have the most advanced, interoperable electronic health records in the world, but without skilled epidemiologists, statisticians, data scientists, and public health analysts, it is just digital noise. These professionals are required to clean the data, design the algorithms, account for the biases we just discussed, and ultimately convert raw numbers into actionable narrative insight. The technology is the tool. The analysts provide the intelligence.
So we've built this massive, interconnected, intelligently managed nervous system. But data sitting on a server doesn't cure a patient. How does this system actually change what a doctor prescribes on a Tuesday morning? Let's transition to how this transforms practice.
This brings us to a pervasive and often uncomfortable reality in modern medicine, which we can call the lottery of routine care. We like to imagine that clinical medicine is entirely evidence-based, but in areas where definitive clinical trials haven't been conducted, treatment often relies on local habit, individual physician bias, or historical precedent.
An example of this is prescribing antibiotics for mild to moderate exacerbations of chronic obstructive pulmonary disease, or COPD. If you look at the EHR data across a large region, you see massive, inexplicable variability. Clinic A routinely prescribes a course of antibiotics for almost every COPD exacerbation. Clinic B, just down the road, almost never does, preferring to manage it with steroids and bronchodilators.
From a systems perspective, this variability is a failure. It means patients are receiving fundamentally different standards of care based on an invisible lottery of which doctor they happen to see. Furthermore, treating patients inconsistently in an uncoordinated way generates no new evidence. We don't learn if Clinic A or Clinic B has the better approach.
Because nobody is systematically tracking the outcomes in a controlled manner. But the EHR infrastructure offers a way to fix this without spending tens of millions of dollars on a traditional clinical trial.
The solution is point-of-care randomization. It leverages the existing electronic health record to run large-scale pragmatic trials seamlessly within routine clinical practice.
Walk me through what point-of-care randomization actually looks like for the clinician.
Imagine you are a primary care physician. A patient presents in your clinic who is eligible for a statin to manage their cardiovascular risk. There is genuine, documented clinical uncertainty in the medical community about whether simvastatin or atorvastatin is superior for this specific patient demographic in a real-world setting. In the past, you would just pick one based on your personal preference, but with point-of-care randomization, the EHR actively intervenes.
The software flags the clinical scenario.
Yes. A prompt appears on your screen noting that the patient is eligible for a pragmatic trial. It asks if you and the patient are willing to randomize the choice of statin. If the patient consents, you click a button and the EHR's algorithm randomly assigns either simvastatin or atorvastatin right there at the point of care. The prescription is generated automatically.
That eliminates the bias of the physician choosing the drug. But what about the follow-up? Traditional trials require massive infrastructure research nurses calling patients, bringing them in for specific testing, meticulous data entry.
That is the genius of using the linked data systems we discussed earlier. In these pragmatic trials, like the RetroPro trial mentioned in the public health literature, the follow-up happens almost entirely invisibly, utilizing routine data collection. If the patient suffers a heart attack 2 years later, it is automatically captured in the hospital admission data. If they pass away, the Vital Statistics Registry records it. If they stop picking up their statin prescription due to side effects, the pharmacy dispensing data flags it.
So the researchers are gathering real-world efficacy data at a fraction of the cost of a traditional trial on highly representative everyday populations without altering the patient's normal routine or burdening the clinician with extra paperwork.
Exactly. And this methodology can be scaled up even further through cluster trials.
How does a cluster trial differ from what we just described?
In a cluster trial, you don't randomize individual patients. You randomize entire healthcare environments, like a whole primary care clinic or a specific hospital ward. Suppose public health officials want to test whether an electronic decision support prompt on the computer screen can reduce unnecessary antibiotic prescribing for simple viral upper respiratory infections.
You can't test that patient by patient with the same doctor. If the doctor sees the prompt for patient A, they will learn from it and alter their behavior when they see patient B, even if patient B is supposed to be in the control group.
Correct. The intervention contaminates the control. So instead, you randomize 50 clinics to receive the new electronic prompt and 50 clinics to continue with their standard software. Then, using the administrative prescribing data, you measure the overall rate of antibiotic dispensing across the two distinct clusters of clinics over 6 months. It evaluates interventions at the system level.
This ability to track real-world data brings us to a crucial concept impact assessment. And there is a specific, sobering example regarding selective COX-2 inhibitors, or COXIBs. Why is it so necessary to evaluate drugs after they have already passed rigorous clinical trials and been approved by regulatory agencies?
Because efficacy in a controlled trial does not guarantee effectiveness in the real world. COXIBs were developed as blockbuster pain medications. They were designed to provide the profound pain relief of traditional NSAIDs, but without the high risk of severe gastrointestinal bleeding.
They were supposed to be the safer alternative. And based on the initial randomized controlled trials, health economic models were built proving they were highly cost-effective, which guided clinical prescribing guidelines.
But we have to look at the populations used in those initial trials. To prove the benefit of the drug, the trials were conducted on highly specific ideal populations, primarily patients with severe chronic conditions like rheumatoid arthritis or advanced osteoarthritis who required continuous high-dose pain management and were therefore at the highest risk for GI bleeding from older drugs. In that specific cohort, the COXIBs were highly cost-effective.
But what happened when the drugs hit the open market?
When researchers later used EHR data to conduct an impact assessment, looking at how the COXIBs were actually being prescribed in routine daily practice, the findings completely shattered the economic models. The real-world data showed that the vast majority of COXIB prescriptions were not going to patients with severe rheumatoid arthritis. They were being widely prescribed by GPs for short-term intermittent pain, a sprained ankle, a tension headache, mild back pain.
Meaning the drugs were being given to patients who had a very low baseline risk of GI bleeding anyway, and who wouldn't have even met the inclusion criteria for the original clinical trials.
Precisely. The initial cost-effectiveness models lacked external validity. They modeled an ideal hypothetical scenario, completely failing to account for how aggressive pharmaceutical marketing and shifting physician habits would expand the use of the drug into low-risk populations where it was no longer cost-effective. The fundamental lesson for public health is that we must move away from solely evaluating interventions in ideal controlled settings. We must use our information systems to relentlessly measure what actually happens in real populations.
We must measure reality, not the hypothesis. Okay, we are going to pivot sharply here. We have spent the first half of this deep dive mapping out the nervous system, how public health gathers, links, and processes information from people interacting with the healthcare system. Now we are turning on the active radar. We are moving into the concepts of population screening.
If the information systems are passive, waiting for a patient to generate data, screening is aggressive. It is the systematic process of sweeping the horizon, actively looking for hidden biological threats in people who feel perfectly fine and have no symptoms.
And right out of the gate, we need to establish a very rigid conceptual boundary. The public health definition of screening is highly specific, and it is frequently misused in daily clinical parlance. We need to define what screening is not.
Terminology is critical here because the ethical and operational frameworks change depending on what you are doing. Let's say you have a patient diagnosed with type 2 diabetes in your clinic. Every year, you systematically examine their retinas, perhaps using digital photography, to check for diabetic retinopathy. Many clinicians call this diabetic eye screening. From a public health framework, that is incorrect. That is the systematic clinical management of a patient with a known existing disease to monitor for complications.
Okay, what about this scenario? A 45-year-old man comes into my clinic. He's there because he twisted his knee playing tennis. But while he's there, he mentions his father recently had a heart attack, and he asks if I can check his cholesterol. I draw a lipid panel. Is that screening?
No. That is classified as case finding or opportunistic testing. It is initiated either by a specific patient concern, a family history risk factor, or because the patient has already presented themselves to the healthcare setting for another reason. The clinician is taking the opportunity of the clinical encounter to run a test.
So then what is true? Prescriptive population screening.
Prescriptive population screening is a proactive public health service initiated by the state or the health system. It is the systematic offer of a test to a defined, asymptomatic population who do not perceive themselves to be at risk and have not sought medical attention for that issue.
So it's the National Health Service sending a letter to every single 50-year-old woman in the country, inviting her for a mammogram, regardless of her family history or how she feels, or mailing a bowel cancer testing kit to the home of every 60-year-old man.
That is true population screening.
Yeah.
And understanding that definition brings us directly to the core paradox of screening. This is a concept that is often very difficult for the general public and sometimes even clinicians to fully reconcile.
The paradox is rooted in who you are targeting. When a sick patient comes to a doctor, they are already suffering. They have a problem that needs solving. In that scenario, the potential benefits of a treatment usually far outweigh the risks of the intervention. But screening flips that dynamic on its head.
With a prescriptive screening program, you are actively reaching into the lives of people who consider themselves healthy. You are asking them to undergo a medical procedure they didn't ask for. Because you are intervening in a healthy population, the ethical bar is fundamentally different. The potential to do massive harm on a population scale is incredibly high.
Let's categorize those potential harms because it's not just about the cost of the test. What kind of harm does screening cause?
First, there is the direct physical hazard of the screening test itself. If you screen for bowel cancer with a colonoscopy, a certain percentage of those healthy people will suffer a bowel perforation, a life-threatening complication. If you screen with mammography or CT scans, you are exposing millions of healthy people to cumulative doses of ionizing radiation, which itself can induce malignancies.
And beyond the physical, there is a profound psychological toll.
The psychological harm of a false positive result is immense. Imagine telling a perfectly healthy person that their screening test indicates they might have cancer. They spend weeks in agonizing anxiety, undergoing further invasive biopsies and scans, only to finally be told it was a false alarm. You have inflicted severe psychological trauma on a healthy citizen.
And perhaps the most complex harm is overdiagnosis and overtreatment. We will dive deeper into this later, but essentially, screening can find borderline abnormalities or incredibly slow-growing cellular changes that meet the pathological definition of a disease, but which never would have actually caused the patient any harm during their natural lifetime. Yet, once found, the clinical reflex is to treat it. So you end up performing surgery or radiation on a patient who didn't actually need it.
Because the potential for harm is so significant, a health system cannot simply launch a national screening program just because a new diagnostic test has been invented. There must be an intellectual and ethical firewall. This is where the Wilson-Younger criteria come in. Originally developed for the World Health Organization in 1968 and adapted by national bodies ever since, these criteria define the absolute prerequisites that must be met before screening can commence.
There are quite a few criteria, but let's highlight the most critical ones to build the framework. First, the condition being screened for must be an important health problem. You don't screen for something trivial. Second, there must be a simple, safe, precise, and validated screening test that is acceptable to the population. If the test requires a painful lumbar puncture, healthy people won't agree to it, and the program fails.
Third, the natural history of the condition must be adequately understood. This means we must understand the biological progression of the disease from its latent asymptomatic phase to declared clinical illness. If we don't understand how long a precancerous lesion typically takes to become invasive, we don't know how often we need to screen, or if intervening during the latent phase actually changes the outcome.
Fourth, all cost-effective primary prevention should have already been implemented. It makes no sense to spend billions screening for a disease if the government hasn't first instituted basic public health measures, like tobacco taxation or clean air regulations, to prevent the disease from occurring in the first place. But there is one criterion that acts as an absolute, non-negotiable hard stop.
The treatment prerequisite. You cannot ethically screen for a disease if there is no effective treatment or intervention for the patients you identify. Finding a disease early is completely useless if you have no way to alter its course. Furthermore, there must be robust evidence that treating the disease early in its asymptomatic phase leads to significantly better outcomes than waiting to treat it when it naturally presents with symptoms.
And this extends beyond just having a drug available. The clinical pathways must be ready. The criteria state that the clinical management of the condition and patient outcomes must be optimized in all healthcare providers prior to commencing the screening program.
This is a vital systems thinking concept. Imagine a government decides to launch a highly sensitive newborn screening program for a rare metabolic disorder. The screening test works perfectly. But if the government hasn't adequately funded the specialized pediatric metabolic clinics required to receive, counsel, and treat these infants, the screening program is profoundly unethical. You are systematically handing parents a terrifying diagnosis without providing a functional pathway for care. A screening program is not just a laboratory test, it is the entire end-to-end clinical pathway.
Okay, let's drill down into the mechanics of the test itself. When we run a radar system, we need to know its specifications. We're moving into the mathematical frameworks of diagnostic accuracy in low-prevalence environments. Let's define the two basic properties of any diagnostic test.
We need a solid grasp of sensitivity and specificity. Sensitivity is the proportion of subjects with the actual disease who are correctly classified as true positives by the test. Think of it as the test's ability to find the disease when it is genuinely present. Specificity, on the other hand, is the proportion of disease-free subjects who are correctly classified as true negatives. This is the test's ability to correctly ignore healthy people.
Now, if I put on my clinician hat, my immediate instinct is that I want a test with the absolute highest possible sensitivity. If I'm looking for cancer, missing a case feels like a catastrophic clinical failure. I want the net to catch every single potential anomaly.
And that clinical instinct is exactly what leads into the specificity trap. This raises an important question. In a hospital ward full of sick, symptomatic patients, prioritizing high sensitivity makes sense. But when you transition to population screening, you have to fundamentally shift your mathematical framework. In population screening, specificity is actually king.
Why does specificity become the dominant metric?
It entirely comes down to disease prevalence. The conditions we screen for in the general asymptomatic population usually have prevalence of less than 1%, often much less. When you are deploying a test across millions of healthy people, even a microscopic error rate in your specificity will generate an absolute avalanche of false positives that will crush your healthcare system.
Let's walk through the math of this carefully, focusing on a metric called the positive predictive value, or PPV. As a patient, PPV is the only number I actually care about. If my doctor calls and says, your screening test came back positive, my immediate question is, what is the actual percentage chance that I truly have this disease? That is the PPV.
Let's build a scenario. Imagine a disease with a 0.1% prevalence in the general population. 1 in 1,000 people genuinely have it. Now, medical engineers develop a fantastic new screening test. It has 95% sensitivity and 95% specificity.
To the layperson, a test that is 95% accurate sounds phenomenal.
Let's run the numbers on a population of 10,000 people. With a 0.1% prevalence, exactly 10 people in that group of 10,000 truly have the disease. We apply our test with 95% sensitivity. It successfully finds 9.5 of them. For the sake of the math, let's round that to 9 true positives. We miss one case.
Okay, we found 9 people who need help. But what happens to the other 9,990 people who are perfectly healthy?
This is where the specificity kicks in. The test has 95% specificity, which means it correctly identifies 95% of healthy people as negative. However, it incorrectly flags 5% of those healthy people as having the disease. 5% of 9,990 people is roughly 500 people.
So our screening program has successfully found 9 true positives, but it has simultaneously generated 500 false positives.
Now calculate the positive predictive value. The BPV is the number of true positives divided by the total number of all positive test results. So 9 divided by 509.
That yields a positive predictive value of less than 2%.
Let that sink in. We used a highly advanced 95% accurate test. Yet, when a patient receives a positive result, they only have a 1.7% chance of actually having the disease. Over 98% of the time, the system is just terrified a healthy citizen and place them into a cascade of unnecessary, expensive, and potentially hazardous follow-up diagnostics.
The sheer volume of healthy people mathematically overwhelms the accuracy of the test. The radar screen gets so cluttered with false blips that the real targets are lost in the noise. There is a brilliant real-world example of this mathematical reality involving screening for beta thalassemia carrier status. Can we break down how prevalence altered the reality of that program?
Beta thalassemia is a genetic blood disorder. When screening populations to see if they are carriers of the trait, clinicians analyze the blood's mean cell hemoglobin, or MCH. They use a specific cutoff point to determine who needs further genetic testing. Historically, using an MCH cutoff of 27 picograms provided a sensitivity of 100%. It caught absolutely everyone.
And if you use that 27 picogram cutoff in a high-prevalence setting, say, an antenatal clinic in a specific London borough serving a demographic with a high rate of the genetic trait, the math works out. In that specific setting, the positive predictive value is around 77%. If the test is positive, there's a very high likelihood the patient is actually a carrier.
But the dynamic completely collapsed when policymakers attempted to roll out that exact same test with that exact same 27 picogram cutoff as a universal screening program across low prevalence areas of the country. Because the underlying prevalence dropped drastically, the PPV plummeted to as low as 1.3%. The laboratories were suddenly drowning in false positives. The healthcare system realized it would completely collapse under the administrative and financial weight of having to recall and genetically counsel thousands of healthy partners based on a 1.3% true positive rate.
The specificity trap caught them, so how did the system engineer a way out of it? They needed to increase the specificity without inventing a new blood test.
They optimized the pathway by adding a clinical filter before the lab test. They realized that in low prevalence areas, they had to ruthlessly weed out the false positives. They achieved this by integrating a simple family origin questionnaire into the initial screening encounter.
So instead of treating every blood sample equally, they used demographic risk to adjust the threshold.
Precisely. If a patient's family origins indicated the very low risk of thalassemia, the laboratory would apply a much stricter criteria before flagging the blood test as positive. By combining the biological test with targeted demographic questions, they massively increased the specificity of the overall screening pathway.
And what was the operational result of that change?
The impact was staggering. By adding that simple clinical filter to increase specificity, the program reduced the rate of unnecessary partner recall by 96%. It is the perfect real-world proof that without a ruthless, obsessive focus on high specificity, population screening programs become self-destructive. They waste vast resources, they inflict psychological harm on healthy people, and they rapidly lose the trust of the public.
Okay, let's broaden the lens now to look at the macro-level implications of these programs. We are moving into the spheres of economics, governance, and a fascinating behavioral phenomenon. Let's start with the economics. Evaluating the cost-effectiveness of a screening program is notoriously the most difficult health economic evaluation to perform. Why is it so much harder than evaluating a new pharmaceutical drug?
When you evaluate a new drug for a sick patient, the timeline is usually relatively short months or a few years, and the endpoints are clear. Screening requires a massive, multi-decade societal perspective. Because you're intervening in healthy populations, you have to utilize complex lifetime modeling. If you screen a 50-year-old for bowel cancer today, you have to mathematically model the clinical, financial, and quality of life impacts over the next 30 to 40 years of their life.
And the economic models frequently fail to account for the hidden systemic costs of screening. What kind of hidden costs are we talking about?
People often assume the cost of a screening program is just the cost of the mammogram machine or the lab test. That is a fraction of the reality. What about the economic productivity lost when 500 healthy people have to take 2 days off work to undergo colonoscopies because of false positive results? What about the vast ongoing cost of quality assurance?
Quality assurance at a national scale must be a logistical nightmare.
It is incredibly resource intensive. It's relatively straightforward to train a small team of specialized doctors in a single tertiary center. It is a completely different operational reality to continuously train, monitor, and quality assure tens of thousands of radiographers, lab technicians, and nurses across hundreds of disparate geographic locations to ensure they are all performing the screening test at the exact same rigorous standard day after day. If quality assurance slips, specificity drops, and the harms multiply. The sheer administrative overhead of a national screening program is monumental.
Let's shift from the financial cost to the ethical tension inherent in screening. There is a constant push and pull in public health governance between the concept of stewardship and the principle of individual autonomy.
Stewardship represents the ethical imperative of the state to protect and maximize the health of its population. This utilitarian drive often pushes governments toward implementing broad, systematic screening programs. They look at the macro data and see that they can prevent a certain number of deaths. However, this stewardship must be carefully balanced against individual autonomy, the fundamental right of an informed patient to make sovereign decisions about what happens to their own body.
The tension arises because true, genuine informed consent in the context of screening is incredibly difficult to achieve.
Communicating complex probabilities to the general public is a profound challenge. How do you clearly explain a 1.3% positive predictive value to a patient who is terrified they might have cancer? How do you explain the concept of overdiagnosis, that the program might find a cancer and they might undergo surgery for it, but it actually wasn't going to harm them? Distilling these statistical nuances into a leaflet that allows for genuine informed choice without overwhelming the patient or coercing them is a constant struggle.
And this ethical tension becomes even more acute when we discuss genetic carrier screening, particularly antenatal screening. When the state begins systematic programs that can influence reproductive outcomes, like screening for Down syndrome or genetic traits, we have to be acutely aware of the historical context.
Whenever a health system implements population-wide genetic screening, it operates in the historical shadow of eugenics, the idea of systematically altering the genetic composition of a population. To ensure these programs remain ethically sound, the governance framework must be incredibly rigid. The objective of an antenatal screening program must never be to eradicate specific genetic traits or reduce the birth rate of individuals with certain conditions. The sole, justifiable objective is to provide prospective parents with accurate, non-directive information, empowering their autonomy to make the reproductive choices that align with their own values.
The objective is information, not engineering. Now, I want to explore one of the most counterintuitive and fascinating concepts in public health policy. Let's imagine a scenario where a screening program has been running for years. Eventually, independent epidemiologists conduct a rigorous retrospective review and definitively prove that the program is actually causing more harm than good, perhaps through massive rates of overdiagnosis and surgical complications. The logical step is to shut the program down. Why is it nearly impossible to turn off a screening program once it has started?
This is a phenomenon known in public health as the popularity paradox. It is a brilliant and tragic intersection of statistics and human psychology. Let's walk through how it develops. Imagine a screening program detects a tiny, highly indolent, slow-growing cellular anomaly in a patient's prostate or thyroid. Based on its biology, this anomaly never would have progressed to cause symptoms, and the patient would have eventually died of old age or something completely unrelated, never knowing it was there.
But the screening radar swept over them, found the anomaly, and the clinical pathway labeled it as a disease.
Yes. The patient is diagnosed, and they subsequently undergo surgery, radiation, or chemotherapy. From an objective epidemiological standpoint, that patient suffered overdiagnosis and overtreatment. They were subjected to the severe risks of surgery and the toxicity of treatment for an anomaly that posed no threat. They were objectively harmed by the program.
But that is not how the patient experiences it.
Not at all. Subjectively, that patient's narrative is entirely different. They were told they had a disease, they received treatment, and they are still alive. Therefore, they genuinely and passionately believe that the screening program saved their life. They identify as a survivor, and they attribute their survival entirely to early detection.
And because overdiagnosis is so prevalent in certain types of screening, the program essentially mass produces these survivors.
Exactly. You create an army of thousands, sometimes millions, of individuals who have been subjected to overdiagnosis. They form patient advocacy groups, they share deeply emotional stories in the media, and they become fierce political defenders of the screening program.
That is the popularity paradox. The very harm the program causes, unnecessary diagnosis and treatment, generates the emotional and political capital that makes the program incredibly popular and fiercely defended.
Politicians are highly sensitive to this dynamic. Launching or expanding a screening program is politically advantageous. It demonstrates action against a feared disease. But attempting to shut down a screening program, even when armed with incontrovertible data that it is causing population harm, is political suicide. Epidemiologists armed with spreadsheets and statistics about overtreatment rates are completely outmatched in the public arena by emotional, compelling stories from patients who believe the program saved their lives.
There are two distinct case studies that perfectly illustrate this inertia. One is a failure to stop, and one is a rare success. Let's look at the failure first, involving tuberculosis.
In the mid-20th century, Denmark instituted mandatory tuberculosis X-ray screening for certain industrial workers, notably in large breweries like Carlsberg. At the time, when TB was rampant, it was a justifiable intervention. However, as living standards improved and treatments advanced, TB was effectively eradicated in that specific demographic.
So the screening program had accomplished its goal and the threat was gone. They should have stopped screening.
They should have. But the administrative machinery, the established clinics, and the political inertia were so entrenched that it took Denmark over 20 years to finally dismantle the screening stations. For 2 decades, they routinely subjected thousands of healthy workers to unnecessary ionizing radiation from chest X-rays, actively causing harm, simply because it was too organizationally difficult to turn the machine off.
And what about the success story? How do you successfully dismantle a harmful program?
A notable success occurred in Japan regarding infant neuroblastoma screening. Japan had instituted a widespread urine screening program for neuroblastoma in infants. Over time, independent international panels reviewed the long-term data and reached a disturbing conclusion. The screening program was not reducing the mortality rate of neuroblastoma, but it was causing immense harm through the overdiagnosis and subsequent aggressive surgical treatment of benign tumors in infants.
So how did Japan manage to stop it without triggering the popularity paradox?
A convergence of factors allowed for evidence-based policymaking. First, because the condition was relatively rare and affected infants, there were no massive, entrenched adult advocacy groups to politically defend the program. Second, the medical and scientific community formed a unified consensus based on the data. Third, and perhaps most importantly, the Japanese media acted responsibly. Instead of sensationalizing the issue or running emotive denial of care stories, the media accurately reported the scientific findings that the program was inflicting harm on infants. In 2004, the government successfully halted the screening program. It requires a rare alignment of clear data, professional consensus, and responsible communication to stop a harmful initiative.
Let's bring all these concepts together as we survey how screening is applied across different stages of life and dive into the two crucial statistical illusions that obscure our understanding of cancer screening. We'll start with a brief look at the life course.
The application of screening changes dramatically depending on the age demographic. It begins antenally with screening for fetal anomalies, chromosomal conditions like Down syndrome, and infectious diseases such as HIV and syphilis to prevent vertical transmission. Then we have newborn screening, typically utilizing a blood spot test to detect metabolic disorders like phenylketonuria, congenital hypothyroidism, sickle cell disease, and cystic fibrosis.
As individuals move into adolescence and young adulthood, the strategy often shifts. As we discussed earlier, we rely more on opportunistic testing, such as offering a chlamydia test when a young person visits a sexual health clinic, rather than prescriptive whole population screening.
Let's pause on the newborn screening phase because it introduces a profound ethical and operational dilemma regarding the carrier state.
What exactly is the dilemma when we screen a newborn's blood?
When a laboratory analyzes a newborn's blood spot for conditions like sickle cell disease or cystic fibrosis, the biochemical assay doesn't just identify the infants who actively have the disease. It simultaneously identifies the infants who are healthy carriers of the genetic trait. This creates a complex governance decision. Does the health system have a duty to reveal this incidental carrier status to the parents?
What is the argument for keeping that information from the parents?
The argument centers on the infant's future autonomy. The child is a newborn. They cannot consent to having their genetic information analyzed or shared. Furthermore, being a healthy carrier has no impact on their childhood health. The information only becomes relevant decades later when they are making their own reproductive choices. Some ethicists argue that revealing this status to the parents violates the child's right to an open future and their right to decide who has access to their genetic data.
But the prevailing consensus in many high-income countries leans toward disclosure, correct?
Yes. The prevailing view is that parents have a right to the medical information generated about their child. However, this disclosure must be managed meticulously. If a system decides to report carrier status, it must be accompanied by immediate, high-quality genetic counseling,
Why is the counseling so critical?
because the potential for severe misunderstanding is massive. Parents can easily confuse being a healthy carrier with having the active disease, leading to intense anxiety and potentially altering how they interact with their healthy child. Furthermore, the infant's carrier status provides genetic information about the parents themselves. The counseling is required to help the parents understand their own reproductive risks for any future pregnancies. It highlights how a simple blood test on a newborn reverberates through the entire family structure.
Let's move into adult cancer screening. If you are listening to this and building your mental frameworks, the next few minutes are paramount. We need to dissect two critical biases that distort survival statistics. If you do not understand these biases, you cannot accurately evaluate whether a cancer screening program is actually saving lives or just creating statistical illusions. Let's start with length time bias.
Length time bias explains why a screening program will almost always appear highly effective, even if it is completely useless at catching deadly cancers. It is a distortion of the types of cancer the program detects. To visualize this, let's use an analogy. Imagine tumors are animals moving across a field. Some tumors are aggressive, fast-moving birds. They grow rapidly, spread quickly, and are highly lethal. Other tumors are slow, plodding turtles. They grow at a glacial pace, remaining asymptomatic for years.
And your screening program is a net that sweeps across the field once every 3 years. Which animals are you going to catch in the net?
You are disproportionately going to catch the turtles. Because they move so slowly, they spend years lingering in the latent asymptomatic phase, practically waiting to be caught by the periodic sweep of the screening net.
But what about the birds, the aggressive cancers?
The aggressive tumors grow so rapidly that they often develop, cause severe symptoms, and clinically present in the intervals between your screening rounds. The patient feels a lump or develops pain and goes to the doctor long before their next scheduled screening appointment.
So the screening program inherently selects for slow-growing, indolent disease.
Precisely. And because these slow-growing turtle tumors naturally have a much higher survival rate due to their biology, the screening program points to all these survivors and says, look at our incredible success rate. We caught these cancers early and the patients survived. But it's an illusion. They are claiming credit for the underlying biology of the slow-growing tumor. Meanwhile, the program is missing the aggressive, fast-growing interval cancers that actually drive mortality. That is length time bias.
That is a brilliant way to conceptualize it. The net favors the slow. Okay, what about the second illusion, lead time bias?
If length time bias distorts the type of cancer we catch, lead time bias distorts the time of survival without actually altering the ultimate date of death. Let's map out a clinical timeline. Imagine a patient develops a microscopic cancer at age 55. Without any screening, the cancer grows silently for 13 years. Finally, at age 68, the tumor grows large enough to cause symptoms. The patient goes to the doctor, is diagnosed, receives standard treatment, but unfortunately the cancer is lethal and the patient dies at age 70.
Okay, so the timeline without screening is diagnosis at 68, death at 70. The clinical survival time from the point of diagnosis is exactly 2 years.
Now, let's replay that exact same patient's life, but we introduce a screening program. The radar detects the microscopic cellular anomaly much earlier at age 60. We initiate early treatment, perhaps surgery, or early chemotherapy. However, for this specific type of cancer, the early treatment isn't a cure. It doesn't alter the fundamental biological trajectory of the disease. Despite the early intervention, the patient still dies at exactly age 70.
So the intervention changed nothing about the ultimate outcome.
No. But look at what happens to the statistics. The screening program records that this patient was diagnosed at age 60 and died at age 70. They record a 10-year survival time. The advocates for the screening program compare the 10-year survival time of the screened cohort to the 2-year survival time of the unscreened cohort and declare a massive historic victory against cancer.
But the patient didn't gain a single extra day of life. They still died at 70.
Exactly. They gained 0 extra lifespan. What they gained was 8 extra years of knowing they had cancer, 8 extra years of anxiety, medical appointments, and the toxic side effects of early treatments. The screening program didn't extend their life. It simply moved the date of diagnosis backward in time. That is lead time bias.
The only way to defeat lead time bias when evaluating a program is to ignore survival time from diagnosis entirely. You have to look at the macro data and prove a reduction in overall population mortality for that specific disease. If mortality doesn't drop, you are just stretching the timeline of anxiety. Let's briefly touch on how these complexities manifest in the real-world debates surrounding three major adult cancer screening programs: breast, cervical, and prostate.
Breast cancer screening remains one of the most highly emotive areas of public health. Rigorous analysis of the evidence suggests that mammography programs do lead to a reduction in breast cancer mortality in specific age groups. However, the magnitude of that benefit is fiercely debated, and it comes at the cost of substantial overdiagnosis. The UK, for example, invites women between 50 and 70 for screening every 3 years. But acknowledging the popularity paradox, it is often noted that altering or scaling back these programs requires immense political courage due to intense public advocacy.
Cervical cancer screening has seen massive technological shifts.
Yes. The pathway has evolved from traditional cytology, the Papanicolaou test, to more advanced liquid-based cytology, and now primarily towards testing directly for the human papillomavirus, or HPV, which is the necessary cause for almost all cervical cancers. While cervical screening has demonstrably reduced incidence and mortality, it is highly resource-intensive. Some models suggest thousands of women must be screened for decades to prevent a single death, with a high proportion undergoing investigation for low-grade anomalies that might have regressed naturally. Looking to the future, the widespread implementation of the prophylactic HPV vaccine in adolescents is expected to drastically alter the epidemiology of the disease, potentially superseding the need for intense population-level screening in future generations.
And finally, the perennial debate: prostate cancer.
Prostate cancer presents the ultimate challenge. It is highly prevalent, but as the clinical adage goes, more men die with prostate cancer than of it. The primary test, the PSA or prostate-specific antigen blood test, has a notoriously poor positive predictive value. Based on the current balance of evidence, there is no international consensus supporting systematic population-wide screening for asymptomatic men. The data strongly suggest that the massive scale of overdiagnosis, finding indolent microscopic cancers that will never cause harm, and the severe complications of overtreatment, such as permanent incontinence and impotence from unnecessary prostatectomies, significantly outweigh the potential mortality benefits.
What an incredible journey. We have mapped the entire public health organism from the massive data warehouses of the nervous system down to the complex mathematics and ethical tensions of the early warning radar. Before we sign off, it is time to lock down these frameworks. I'm going to throw 6 rapid clinical scenarios and conceptual questions at you. Treat this like a mental stress test. Wherever you are listening, actively formulate your answer before the expert breaks it down. Let's run the recall prompts.
Question 1. You are evaluating a new diagnostic test to be used in a widespread population screening program. Which specific metric is most heavily and directly degraded by the extremely low underlying prevalence of the disease in the general population?
Take a second to think.
The answer is the positive predictive value, or PPV. In low prevalence settings, even a test with high sensitivity and specificity will yield a low PPV, generating high proportion of false positives. Question 2. A national screening program detects an asymptomatic cancer 3 years earlier than it would have typically presented with clinical symptoms. The patient undergoes immediate treatment. However, retrospective data shows the patient's ultimate age at death did not change compared to unscreened populations. What specific statistical illusion does this scenario represent?
Lock in your answer.
The answer is lead time bias. The early detection simply moved the diagnosis date backward, artificially inflating the survival time statistic but failing to extend the actual lifespan. Question 3. A 55-year-old patient presents to an urgent care clinic with a persistent cough. During the consultation, the physician notes the patient is a heavy smoker and offers a low-dose CT scan to check for lung cancer. What is the precise epidemiological term for this intervention?
What are we calling that?
The answer is case finding, or opportunistic testing. It is not prescriptive population screening because the test was initiated opportunistically during a clinical encounter for a patient presenting to the healthcare system, driven by a specific risk factor. Question 4. According to the Wilson and Younger criteria, what crucial aspect of healthcare delivery must be fully optimized and funded prior to the commencement of any new screening program?
Think about the whole pathway.
The clinical management of the condition and the patient pathways. You cannot ethically screen for a disease if you do not have effective treatments and the optimized clinical infrastructure already in place to care for the patients you identify. Question 5. In the context of linking diverse public health information systems, what is the specific operational role of a trusted third party, or TTP?
How does it protect privacy?
The TTP acts as a secure intermediary that links disparate electronic health records using identifiable patient data, verifies the match, and then cryptographically strips those identifiers to create a pseudo-anonymized dataset for researchers, ensuring privacy while allowing for complex longitudinal linkage. Question 6. A breast cancer screening program reports phenomenal survival rates, but epidemiological reviews show it is missing numerous highly lethal, fast-growing tumors that present between screening intervals. What bias explains why the screening program disproportionately detects slow-growing, benign tumors?
Turtles versus birds.
The answer is length time bias. Aggressive tumors develop rapidly and become clinically symptomatic in the intervals between screening sweeps, while slow-growing tumors remain in the asymptomatic phase longer, making them statistically more likely to be caught by the periodic screening net.
Excellent. If you stumbled on the mathematics of PPV, or the nuances of those biases, I strongly advise returning to chapters 4.1 and 11.4 of the Oxford textbook to solidify those concepts. Understanding the difference between lead time and length time bias is a foundational skill for interpreting medical literature. Now, to close out, I want to leave you with a final provocative thought regarding the future trajectory of these systems. As our electronic health records become seamlessly interoperable, and as our genetic and multi-cancer biomarker screenings become hypersensitive, we are rapidly approaching a clinical horizon where almost no one will be strictly defined as healthy. If our early warning radar can detect microscopic biological risks or genetic predispositions decades before clinical symptoms appear, will the psychological burden of living as a pre-diseased patient outweigh the physical benefits of ultra-early intervention? How will the health systems of the future manage an entire population of the worried well?
It is the defining operational challenge for the next generation of clinical leaders.
Keep building those frameworks, keep questioning the underlying data, and thank you for joining us on this deep dive.